delighted to welcome David Erickson. He's director of the Center for Community Development Investments at the Federal Reserve Bank of San Francisco. He's also edits the Federal Reserve Journal, Community Development Investment Review. He's led the collaboration between the Federal Reserve and the Robert Wood Johnson Foundation in bridging the health sector. And to me, the short way to summarize what he does is how lucky are we within the Federal Reserve Bank is somebody who actually cares deeply about health, communities, and gets that this is all linked to the economy. So I'm particularly thrilled to welcome him here. He has books on the history of community development, the housing policy revolution, networks and neighborhoods, and it co-edited Investment in What Works for America's Communities, essays on people, place, and purpose. So we all know health happens in neighborhoods, and we're going to get to hear his perspective on this. So thank you so much for joining us.
Thanks, Dean. Thank you very much. Well, great. So it's interesting you say that there's nice to have someone at the Federal Reserve that cares about these things, and something that's really nice is to have the head of the Federal Reserve care about these things. So Janet Yellen, who was Berkeley professor, went on to run the Federal Reserve Bank of San Francisco before she became vice chair, and then she's now chair of the whole system. And she is an interesting person because she would be famous just on her academic achievements alone, and now she's the second most powerful person on the earth, and which also makes you kind of famous. And you cannot imagine what a lovely, sweet person she is. So the idea that you could have all of that together in one place is really remarkable. And in fact, she cares very deeply about the anti-poverty work that the Federal Reserve does. I'm going to tell you a little bit about that. She also, her first public speech as chair of the Federal Reserve System was at the conference that I put on an anti-poverty conference in Chicago. Every single newspaper in the world carried that speech. And only two out of like 3,000 mentioned where she was, so I was very upset about that. But then just a couple weeks ago, she gave a speech on income inequality. And this is just unusual. For those of you who follow central banks, this is very unusual. So this is very exciting, and we definitely, at the highest levels, this work has very, very strong support. So I want to just say that, we're going to talk today about how health happens in neighborhoods and what we can do about it. They asked me to do this disclosure at UCSF, so I thought I'd just throw this in here too, but I'm not selling anything to you, so want to make that clear. And I want to just give you a little history about why the Federal Reserve cares about these things. So part of it is that the Federal Reserve is a bank regulator in addition to its responsibilities for monetary policy, that is sort of setting the interest rates and things like that. And this is a map from the 1930s from the Home Ownership Loan Corporation. This was the last time we had a nationwide meltdown in the mortgage market. The federal government had to step in, and there was an effort to try to stabilize the mortgage market. And one of the things they did was to say, we're going to create these maps around the country to show areas where we think, areas in blue and green where we think the mortgages are relatively safe and you can go ahead and buy those, and areas where we think there might be in transition, and areas that were just too risky. These homes aren't valuable enough to lend, to make a mortgage, buy that mortgage. This is Philadelphia, by the way, and it probably doesn't surprise anyone here that this whole area here was African American. And what was going on with this during this time, and this was a pattern that got set in the 1930s and 40s but continued into the 1970s, where banks would be very willing to set branches up in this area and take deposits, but they would not lend back into them. And so what you had was these banks essentially becoming a wealth stripping enterprise. And in fact, this is even, and although I'm telling you this in an American context, this is not unique to the United States. In fact, we were just a couple years ago consulting with the People's Bank of China, and they really have a problem because in the interior, these banks will take deposits from the local farmers and things, but then they immediately start lending it to the coast where all the action is, where all the factories are. So they're doing something very similar, and then these farmers can't get a mortgage, they can't get a small business loan, they can't use the capital that they themselves accumulate to better their own economic circumstances. So the Federal Reserve comes in, and one of our jobs is enforcing the CRA, Community Reinvestment Act, so we make sure banks don't do this anymore, that we make sure that they lend back into those areas. So that's one reason why we're connected. And what's unusual is Federal Reserve is a decentralized central bank, so it's a very classically American phenomenon. And so we have regional headquarters all across the country. You happen to be in the San Francisco branch. It's a San Francisco Fed's district. Los Angeles wasn't nearly as important as it is now in 1913 when this was all laid out. And if we did it today, we probably wouldn't have two banks located in Missouri, but that's the way that kind of went. That was a lot of action there, economic action there in 1913. But basically, the Federal Reserve also has what we call dual mandate. So all central banks all around the world have one job, which is to fight inflation. But the Federal Reserve has a second mandate. Some central banks have this, but not very many, and no major economy has this, where they have to do it at maximum employment. So there's a real social welfare element baked into the DNA of the Federal Reserve, and so this is part of the reason why you'll hear Janet Yellen talk a lot about the dual mandate and how it's important to make sure we're really paying attention not only to Wall Street, but to Main Street as well. That's just some background on the Federal Reserve. I'm going to get a little more history about the community development and the role the Federal Reserve plays in that. But I want to go through some of this sort of just setting up sort of what the problem statement is. And that is the Americans have worse health and shorter lives than they should, given how wealthy the country is and how much we spend on medical care. And these are things you guys know, right? So I can really skip through a lot of this. But you can see that, when you look at how much we spend per capita on medical care, you would think we'd be getting much better health outcomes, but we don't. And the amount of money we spend is just so massive, 2.9 trillion, that it's really sort of just you're dumbfounded by it. And I guess what that brings home to me is that you can't buy your way out of this problem, and that health is not health care. And that's something that, again, you guys will get, but it took me a long time to get this. I mean, seriously, people would say health, and I think medical care, right? And I mean, this went on for a long time. And I'm married to a public health professor. I mean, you would think I would be able to be better at this, But it just took me a long time to get it. And so I like to come back to this sort of statement from the WHO from 1946, right? This idea that what is health if it's not medical care, it's the state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And we come back to this again and again. It's sort of a touchstone statement. And I'm sure all of you, there's so many studies like this. This is the McGinnis study around the causes of premature death. I'm sure some of you are familiar with that. And I just couldn't get my head around this when this was first explained to me, that the idea that those who died prematurely before they should have, that I thought, in my mind, before I learned about the upstream social determinants of health, that would be something like 50-60% was because of bad medical care or the lack of medical care. But in fact, it's a very small percentage. And when they rerun this study every which way, and it's been done so many times, I mean, the range can be big. It could be 10 to 20%, but it's still always a small percentage. And then if you look at these other elements that are really having sort of important influence on persons' health and their lifelong trajectory in health, you see that their environmental exposure, behavioral patterns, and social circumstances create almost 60% of the contribution. And that's something that really, those opportunities and those experiences are really shaped by your physical location, by your neighborhood. And those are things that, as someone who thinks about these things in terms of how you can fix neighborhoods, that's really got my attention. And then, of course, what I love talking to a health group is when you're talking to community developers or finance people, you can't talk about epigenetics, but here I can. And so you can talk about to what extent are these sort of the toxic stress that's experienced in these places sort of turning on the gene expression in a way that's not what we would hope for, right? So there's actually, it's even, the neighborhood maybe have control, even influence over even more than 60%. Now, these are some slides I just brought. I've been borrowed from the Robert Johnson's Commission to Build a Healthy America, and I just want to go through, and this is, again, something this tends to be handier for finance and community development audiences. You guys will get a lot of this. But as you can see, this is life expectancy based on education. This is less than a high school degree and a college graduate. And it's 9 years for men and women difference in life expectancy at age 25 for those differences in educational attainment. I mean, pretty shocking. Income has a similar circumstance. So if you're under the poverty rate, and that's what this dark green bar is here, you'll see that the number of children who are reported by their parents to be in very good health is, with less than very good health, excuse me, is almost 1 in 3 among people who are living under the poverty rate, and only 7% for those who are at 4 times the poverty rate. Poverty rate for a family of 4 is about $20,000. So this would be about $80,000 or more. And you can see a similar sort of gradient here in childhood obesity. And I want to really focus on gradient. You guys know about gradients. But this idea that I think there's, and this is oftentimes when I'm talking to an audience that's not very health savvy or population health savvy, to really bring home the fact that this is not about us and them, people who are middle class and healthy and those who are poor and sick, that this is, that there are sort of gradations all along the way, that everybody at every step we could be a little bit healthier. And I think it's really important too to think about this in terms of how I'm really trying to make the case that this is an everybody problem, right? So it's not just, we talked a little bit about those other demographics about people from different education backgrounds and income, but also by race. And you see that income tends in some ways to trump. This is across Black, Hispanic, and white ethnic groups and racial groups, and you'll see that low-income whites, Blacks, and Hispanics are all faring pretty poorly. That's a real problem. Now, it's a problem for everybody, but poverty is really concentrated. So we have 1 in 4 Hispanics and African Americans living in poverty in the U.S. So I want to shift a little bit here. So that was just, I wanted to go through some demographics about sort of try to describe what I think the problem is. Now I want to focus a little bit, shift our thinking a little bit and think about how does this issue manifest itself over space and over geography. And one of the things where I think this is really a powerful study that came out recently by Raj Chetty at Harvard, his co-author Emmanuel Saez at Berkeley, looking at income mobility in the United States. So income mobility is a measurement that economists use to see what are the opportunity structures in your society. If you're very mobile, you'd have, many of you know the Gini coefficient is one of the measurements of this, but this is a measurement of what is the likelihood of being born in the bottom quintile and ending your life in the top quintile, right? So, and it turns out, and this is, I'm going to steal Richard Wilkinson's joke here, but this is why that's why that joke is kind of funny, that if you really believe in the American dream, you have to move to Denmark, right? So, because Denmark is the wealthy nation with the greatest level of income mobility in the world. But what's interesting is if you disaggregate, so the United States does not fare well in that comparison. We're about middle of the pack, basically. But if you disaggregate the data over space, what you find is that if you were born in Atlanta, whether or not you're white or black, if you're a low-income person, your chances of getting into the highest quintile by the end of your life is very low. So much, the lowest of any wealthy country. All right, so that's really frustrating. What's unusual, particularly is in this area, well, let me put it differently. If you're in San Francisco, Salt Lake City, Seattle, San Jose, you're in the Denmark range in terms of income mobility. There's opportunity structures in those places that is at the same level as the most mobile country in the world. And so I want to just make this point and just kind of park it for a minute, which is that these opportunity structures can vary really drastically over space and by community. And all of these places are experiencing globalization. All of these places are experiencing a change in the economy where there are no longer middle income, low skill jobs. Those are gone everywhere here. They all are under the same federal policies. And yet what we find is some really different outcomes. And so, and I want to make that point that I think there are opportunities to reassemble the building blocks that exist today. Like we don't need an act of Congress. We don't need some huge breakthrough, I think. We really do have the power to reassemble existing building blocks that we have today to get at some of these better outcomes. Just by the way, this is way better than even Denmark, right? So I don't know what's going on in the Dakotas, but they've got something figured out. Yeah. So again, just to bring this issue home around the idea around sort of how this health is distributed over space, opportunities distributed over space. These are a couple of infographics that RWJ put out, again, in that commission to build a healthy America. And what they did was try to put life expectancy near sort of transit hubs. The first one they did was the metro map in Washington, D.C. This one is of New Orleans. And you can see in Iberville, the life expectancy of someone born there is 55 years. And compare that to the Lakewood and the Veer area, just a few miles away. These are exits off of the highway system here, Interstate 10, is 80 years. So this basically the difference between Uganda, which is about what 55 years is, and Japan, the country with the longest life expectancy in the world, right? In one city, right? And there are a lot of these. We did these infographics for a lot of places. We did it for the San Joaquin Valley, Washington D.C. A lot of different places, but I always like to include the one that we did for the Minneapolis St Paul area, because you know, New Orleans is famously poorly run, right? And it's had terrible race relations and a failing economy in many respects. But the Minneapolis St Paul area has one of the lowest poverty rates in the country. You saw on that map that I showed you before about income mobility, very mobile, right? Lots of great institutions here, good schools, low poverty, low unemployment, and still, if you look at Interstate 94, you look at the life expectancy off the different off-ramps, you're going to see some really incredible differences. So here, just 3 miles apart, is a 13-year difference in life expectancy in the Minneapolis-St. Paul region. And in fact, when we did this, we were doing these healthy communities meetings that the dean mentioned before, with bringing together people that RWJ knows and people that the Federal Reserve knows at the Federal Reserve banks around the country. And we did one in Minneapolis. And the film crew came, the local television station reported on it, which was cool. And they interviewed two people from each of these different neighborhoods. And they said to the guy living here, they said, well, what do you think about that? And he said, well, what do I think about it? I think I'm moving to that other neighborhood is what I think, you know. So, but all of this has really sort of just dramatized this very powerful idea that your zip code is more important than your genetic code, something that the Commission's report, the Commission to Build a Healthy America report really brought that home. And I think, you know, community development, what I'm going to talk to you a little bit about is really in the zip code improving business. And I'm going to give you just sort of a very high level discussion about the community development industry. If you're really interested more in it, I would send you to this resource. I'm sorry it's this long. It's 440 pages. Oof. You know, so it reminds me of that letter from Thomas Jefferson where he says, I apologize, if I'd had more time, I would have written you a shorter letter, you know. But it's long, but there's quite a bit of interesting stuff in there in terms of the history of community development and an overview of it and give you a better sense of it. And it's free, by the way. But also, I did a talk at the Mayo Clinic on community development, and you can Google that, my name and Mayo Transform, I think was the name of the conference, and you'll get that. It's much more in depth. But I'm just going to kind of do some very headline overview here. And basically, you know, what community development is, as I said, kind of in the zip code improving business. And it really, and this is, you know, again, one of these things that took me way too long to quite understand, but that your body is the sum record of your challenges and opportunities, which is why these different health experiences are so different in different places with different opportunities and challenges, right? So what community development works on is trying to make more communities challenge or opportunity rich. And so we do things, we don't do as much on Parks and Rec, unfortunately, right now. It's very hard to figure out how to pay that back. But we do a lot of work in terms of small business lending, job training, and sort of other human capital development to get people ready for jobs. We do build a lot of charter schools. Unfortunately, that's the one tool we have at the moment, but we're trying to branch out into doing more work with the public school system, but that's very difficult. There's a $500 million a year program called the Healthy Food Financing Initiative that builds grocery stores in food deserts. And I should say too, when we build something in community development, it's not just a grocery store, right? You'll see the Refresh project and some video that I'm about to show you. But that's a supermarket in New Orleans where they have a kitchen that's really designed to sort of bring community together, teach people how to sort of cook different types of food, come together as a neighborhood, but also do some job training and some skill building so that people could get jobs in the restaurant industry. So it's a grocery store, but it's also a community hub. and job training facility. So that's kind of, everything we do has kind of got that triple or quadruple sort of objective to it. The community development's built about 3 million apartments for about 10 million low-income people across the country. And I'll show you a picture of one of them in a moment, but every single one of those buildings is beautiful. It's a place you would be very proud to live in yourself or have your mother live in. It's really nice. It's not like the Cabrini Green or Pruitt-Igoe or something that you've seen in the past. And then, of course, we do a lot of work with transportation in terms of trying to, as communities start investing in their transit infrastructure, that triggers gentrification pressures. And what we're trying to do the best we can is to take as many parcels of land out of the market so that the people who live there now can continue to benefit from the access to these new investments that can connect them to jobs, good schools, and other opportunities. So that's just some of the stuff that we're working on that we think has a real health implication. Just to put some pictures to that so you get a better sense. Here's an example of an affordable housing project not far from here in North County in San Diego County. And what I love about this one is it's beautiful, right? And I wrote a book about the history of community development a few years ago and interviewed someone who was just moving into one of these projects and who had come from a public housing, one of these more dangerous places, not nearly as nice affordable housing community. And what she said was, I love living here because they're not afraid to deliver a pizza to me, you know. And I know you're not supposed to talk about pizza to health audiences, but it's this idea that she's so proud of where she lived, right? And you can't, you know, I'm sure you guys could measure the value that it gives to her life expectancy, right? The other thing that's cool about this project is that these are all solar panels on the roofs. So this project has no, the tenants in this project, it's a zero carbon footprint project, and none of the tenants here pay a utility bill. This is another example of charter school. This is the Knowledge is Power program. This is in Southeast Washington, D.C., pretty tough, Anacostia sort of tough neighborhood. And what I love about this building too is that, you know, the kid walks through that door and what that building says to that kid is, you live in a society that cares about you and expects a lot from you, right? I mean, it's a beautiful facility that you'd love to live in. I mean, learn in rather. This is a project also in Hawaii. This is a small business development project using a tool we call the New Markets Tax Credit. And it's a huge facility that was on a brownfield site. This was formerly an aerospace manufacturing center. It's a very contested gang environment here. Most of the residents of this area are from southern Mexico. And the person who is a family foundation who was sort of in charge of it, and the woman who was really the program officer kind of leading the charge, she just walked up to people in this neighborhood. This is a neighborhood the police were afraid to go to, by the way. And she just said, "Who are you? You know, do you work in a, are you in a gang?" And I'm like, "Yeah, of course I'm in a gang." And so she said, "I want to talk to your boss." So she talks to all the bosses of all the different rival gangs, and she said, "Look, we want to build something here, but we can't do it if it's going to be a violent place the way it is now." And so they had this big summit, and she said, "What can we give you in return for having this be neutral ground?" And to a one, they said, "We want jobs for our members." And they said, "We'll do that." You know, so to date, this project's 10 years old. There's been none of that violence has returned. It's been very successful. You'll see, I don't know if many of you can see this or not, but it's, the architecture is really interesting, right? So a lot of these people are from southern Mexico. They very much feel a sense of pride towards their Mayan ancestry. And so this is, if you've ever been to Palenque and in southern Mexico, it's really designed after that sort of Mayan, the temples in Palenque. And then in addition, which was interesting about this project, and this is unusual, but it's a cool element, I think, is that they were able to provide equity stakes for the local community to participate in this project. So they could sell a stock certificate, right? You know the difference between, so debt is something you borrow money for, like your mortgage, right? So I own a house, but I don't really own it. The bank owns it. I'm just borrowing their money for a while, and I'm promising to pay it back. I had to put a little bit of money down myself, though. That's the down payment. That would be like equity, right? That's at risk. That's my money. If it succeeds, that's great. And it's like buying any kind of stock, like the Excite stock. So my husband bought Excite stock, which is why we're not going to be naming any public health buildings after ourselves anytime soon. But we lost that money, right? But this community ended up buying into the project, right? They bought into it, and they get a dividend every year. And so what I love about my favorite part about that story is that they say, so at first, when they're meeting with the community groups, getting people excited around it, they say, everyone said, we want local mom and pop shops. We want this to really to showcase local artisans and local work around that. And then once they had an equity stake in it, they're like, yeah, we want McDonald's and Starbucks. We want somebody who can pay the rent. We don't. So at any rate, these are just some examples. There's a ton of these types of things, but I just wanted to give you a feel for what community development is about. But again, so coming back to this idea that health happens in neighborhoods, and there are ways to make neighborhoods better. And I would just say that this is an idea, and I've given this talk, an earlier version of this talk before, and some of you have seen it. I apologize that I'm subjecting you to elements of it again, but it really is true that we're making a ton of progress. Like it was not we had one meeting in Washington D.C. in 2010. We brought together some people from community development, from the public health world, and all the rest. In fact, I was just reminded of a quote from Howard Koh was speaking, and he said we're talking about perspectives, and I was just parking here a minute ago, at lot number 9, and he said, why does it always say 5 masters of public health in a parking structure? Like, why would it say that? And he was saying, oh yeah, it's miles per hour. It's like, but it's really, it kind of dramatizes this idea about, when we say CDC, we think of community development corporations, right? And you might think of a place in Atlanta, like there is so much bridging that has to go on, even at just the level of language is really hard. But that was only 4 years ago. We've had 18 of those meetings since then. We just had the last one in Columbus, Ohio last week. And that one just blew me away, because it was this grizzled old guy from Southern Ohio, very speaking with a twang, old banker, like just looked like the kind of Smith Barney, we earned money the old-fashioned way. You're all too young to even know what that means, but at any rate, he's very much like a hardcore banker. And he got up there and he said, I used to think of myself as a housing guy, but now I know I'm a health guy. And he was readjusting the $250 million that he oversees every year to include the upstream social determinants of health in terms of how they're awarded. And I just thought, God, we're in Columbus, right? This isn't Boston or Los Angeles or San Francisco. This is Columbus, Ohio. You're winning in Ohio, you're winning everywhere, basically. And so there's a lot of excitement. There's a lot of things happening. I would just say, one of the elements that I think part of that too is that I think we're making real progress in terms of, and this is something that the book that I just mentioned is really trying to bring home this message. This is something that I've been talking a little bit about in terms of, this is my history of the community development industry from the last 50 years, or social policy in the last 50 years. In the 1960s, there was sort of a war, there was the war on poverty, and in many ways, health and community development and community empowerment were all together. The community-oriented primary care model of the federal qualified health centers was very similar to how we approach work with the community development corporations. And then we all kind of got siloed off during the time where those institutions really weren't strong enough to execute on this vision, I think. But what's happened over the years is that all of those institutions are getting much stronger, and what we're trying to do now is try to weld them all back together again with some kind of coordination so that we can get back to the vision, which was right, with institutions that are more able to execute on them. We explore this idea in the What Works book with a chapter that I wrote about with a couple colleagues from the Fed on the community quarterback. I'm going to show you a short video on that. But one of my favorite, we try to get as many people to sort of participate in this conversation as possible. And one of my favorite quotes in the whole book was by the head of the Robert Wood Johnson Foundation, Risa Lavizzo-Mourey, and she concludes her essay by saying, "We are likely to look back on this time and wonder why community development and health were ever separate industries." And we've highlighted a lot of examples that were really working, that sort of, that really went into communities where there was 90% bad outcomes. They made these holistic, They were comprehensive, they were place-based, they were data-driven, they were cross-sectoral, and they were able to make these, everything, by the time they were done, it was 90% good outcomes. So you have things like the Harlem Children's Zone, you'll see a little bit of purpose-built communities in Atlanta, Neighborhood Centers Inc. in Houston, some of these examples where they just really had some dramatic turnarounds. What we joke around, and with the running joke though, of when we try to reverse engineer, all of these interventions had these elements to them, but they all were led by a charismatic super genius who had a close friend who was a billionaire. And that's not scalable or replicable. So a lot of what the book is trying to figure out is how to replace the billionaire and how to replace the charismatic super genius, right? So one of the things we were focusing on is this idea about a community quarterback model. So I'm sorry I'm going to play a few videos here. I promise they're short. They're only about 3 minutes each. I only have 3 total, but I'll play 2 really quickly.
Every day, people are working to create opportunities for families and communities across America. They are helping families find jobs, get to work, stay healthy, and have affordable places to live in safe neighborhoods with good schools. This work is critical. It's giving millions of families a shot at the American dream. But in order to truly achieve progress for all of America's families and communities, we must work smarter, be more effective, and work together toward shared goals. By creating partnerships that make the best use of resources, share knowledge, and identify common ground, we can produce remarkable results. With the community quarterback model, we can create new pathways to opportunity through collaboration, team building, working across silos, and focusing on outcomes and evidence. On a football team, the quarterback helps the players work together by calling the plays for the game. What if, instead of a touchdown, the goal was to make sure that every child has the opportunity to realize her full potential? Whether she gets quality education, how she gets to school, if she has healthy meals and regular checkups, can all influence her ability to graduate and succeed in the classroom and beyond. Over her lifetime, this adds up. Every additional year of school she completes represents an 11% increase in her income. Throughout her lifetime, a whole team of players must come together to help her thrive. It's time to rethink how we create progress in America, not only for one child, but a whole generation. We need community quarterbacks to lead the drive to connect people and places, aligning smart policies, smart money, and smart approaches to improve our neighborhoods. We all benefit when a child or neighborhood thrives. It's time to work differently to create opportunity for everyone.
Nearly 1/5 of all Americans live in low-income neighborhoods, where achieving the American dream is often beyond reach, where there are not enough opportunities for a good education, a good job, and good health. For decades, the community development and health sectors have worked to improve the lives in these places, working side by side, perhaps even with the same people, but often not working together. Today, collaboration across these sectors is growing. There are more places where community development and health are working hand in hand to improve both neighborhoods and the lives of the people who live in them, working to reduce poverty and improve health together. Innovators are leading the way, recognizing the importance of places where people live, learn, work, and play. For example, in New Orleans, the Refresh Project offers healthy, affordable food and health education, but also training and jobs as an anchor for workforce and economic development, improving health and improving lives. In the Gulf Coast of Texas, Neighborhood Centers Inc. is dedicated to improving communities and the lives of people in them, focusing on 6 essential components: education, housing, connection, health, economic opportunity, and infrastructure. When a neighborhood reaches its full potential across all of these, the community thrives. In the East Lake neighborhood of Atlanta, Purpose-Built Communities has transformed a once struggling neighborhood into a vibrant, sustainable community by incorporating wellness resources with mixed income housing and a cradle to college education pipeline. Employment has increased from 13% to 70%. Violent crimes fell by 90%, and high school graduation rates are up from 30% to 78%. All of this progress is linked to better health. There are so many bright spots, efforts that are improving health and improving lives, helping people and places, from the urban apartments of the Mariposa Project in Denver, to the Fruitville neighborhood of Oakland, California, and the communities for healthy food in New York City. Examples from around the country show that we can, working across sectors, create better solutions and greater impact. The need to work together is strong, interest continues to grow, and outcomes are promising. But we also know that connections are key. The Build Healthy Places Network is the connector. It's the place to find out what others are doing and to talk about what's new. It's a place to ask questions and to share answers and to get excited about progress and successes across the country. So connect with us on the network and become part of a shared vision, communities where all people can live rewarding and healthy lives.
There's a lot of momentum, hundreds of millions of dollars, totally new business models, a lot of excitement in this work. But I think, just to ground this conversation, what we're up against, we've got, the challenge is massive, right? And I don't need to go into all of these different sort of statistics that are so depressing. But I'd say, typically, historically, what you've found is that poverty would rise and fall, and of course would follow the business cycle. But what we're finding is that in fact, there's a decoupling of poverty in the business cycle, and it's increasing every year despite economic growth. And what's even more disturbing is a near doubling of those who are living in deep poverty, half the poverty rate, that is, family of four making less than $10,000 a year, is doubled in the last 20 years and is at historic highs. So we're really up against a very big challenge that when you get down to it, the solution scale does not match the problem scale. These projects are definitely exciting, but they are not what we need in terms of what's necessary. They're showing the way, they're prototypes, but we need something much bigger to get there, and that's what we're focusing a lot now on systems change. And this is, this is my favorite quotes. William Gibson is a novelist that he's the one who coined the term cyberspace, actually, and his says the future is here, it's unevenly distributed, and that, to me, that really speaks to that Raj Chetty slide. This idea that and these prototypes, there are places where we're getting it right, and we just had to figure out how to make that everywhere. And one of the things I think is true everywhere are these building blocks that exist in terms of ideas, partners, money, capacity, creativity, and shared values. Those are present everywhere we go. You have all of these partners that you just may not have thought about. Those of you in public health may have thought about a hospital as a partner, but you may not have thought about a bank being a partner or social entrepreneurs being a partner. But all these people are all working on the similar issues as we are and as you are. And so we think we're building these sort of communities of practice, these connections, but we've got a long way to go. But these are true. These are present everywhere. You don't have to be lucky to be born into a high-functioning place that has these great sort of visions and great institutions. Every place has these things. And what we're really trying to do is, in terms of our evolution, I mean, you had these kind of sort of voices crying in the wilderness, people like Lynn Syme at Berkeley or Neil Halfon talking to us about why we needed to think about the upstream social determinants of health. I think we're in this stage now. A lot of people get this. Hundreds of millions of dollars are flowing to it. Prototypes are up and running and getting great outcomes. What we need to do is get to the point where this is something where it's the norm, right? The title of the chapter that I wrote in this book was Routinizing the Extraordinary. How do we make it so that the systems are in place so that regular people can get extraordinary outcomes? And so what we think is really important for that is some changes around three important systems. One is data, and I've said before, we're different ships on the sea, and we're trying to sail to the same spot on the horizon. We have to use the same compass. And I think one sort of low-hanging piece of fruit on this is maybe the public health reports that are done at the county level could be combined with the community health needs assessments that the hospitals are doing, and we do an assessment for the banks called the performance context. And in fact, my group has just taken over that function from our supervision and regulation folks, where we're trying to sort of insert as much as we can upstream social determinants of health as an element of that. But I think there's a real possibility of bringing these things together just on that alone. I think in terms of policy, the Affordable Care Act is really sort of a game changer in this regard. I mean, a total game changer. And that not only, but many of those changes were happening before. So you can think about accountable care organizations are inherently silo busting in the way they approach the problem. Coordinated care organizations in Oregon, I think, are really promising. The accountable care communities, you see those in Ohio. There are lots of examples where that's happening. But the other piece here is that you see in King County an effort to merge their public health department with their community development department. There's the former mayor of Los Angeles created a position, cabinet level position, that coordinated transportation, anti-poverty work, and other social services at the cabinet level. So we're trying to figure this out, and there are changes at the policy level that are really exciting. I think the other issue around finance is a lot of the change is going to happen with pay for success financing. A lot of it may come from you tapping into some of that $2.9 trillion to sort of do some of the upstream social determinants of health. We think that there's a lot of money to be made to sort of make more of these connections happen, make it easier to make an Eastlake or Neighborhood Centers Inc. or these other successful prototypes everywhere in the country. I'm not pandering to you necessarily with the cute baby, but the point I'm trying to make here is Lynn Syme, who's been a real public health professor at Berkeley, who's been a real sort of mentor for a long time, he was saying, look, I've done this work for many years. I mean, he's done it for a lot. The guy's like 127 years old. But he says, look, I've looked at all the numbers, I do all the analysis, but I can walk up to someone, I can tell whether or not they're healthy or not because they have bright eyes. And the point is that all kids are born with bright eyes, and what we need to do is sort of get ourselves into the bright eyes business, and so that make sure that kid wins, that the families win, employers win, the economy wins, and we all win. And so I think we've got some momentum. We just have a lot of work to do. So thanks so much for listening to me this morning.
Thank you so much. So I think we have time for a couple of questions or comments.
So other than being kind of what we call the convener and sort of the banking sort of community development, what other sort of core functions does the Fed offer in incentivizing groups to move into this space?
So I often say that we're really effective because we have no money and no power. And that's really helpful in some respects.
Same problem.
Right. Well, it's really helpful because we don't have a dog in the fight, and we've got a good brand, and we've got pretty good real estate, so we can go have these meetings in 18 cities around the country, and when we invite people, they come, so that's good. There's a little bit of, but that's not entirely true. As a bank regulator, we can, one of the things we were talking to our bank examiners, and they said, look, every community just needs affordable housing and small business loans. And we were talking, this was a bank in Fresno that they were doing an analysis of, and I said, well, they've got the highest asthma rate in the country, right? And there's this new social impact bond, an asthma abatement social impact bond that's in the works with some money from the California Endowment. And I said, and you could get CRA credit, Community Reinvestment Act credit, by investing in that. And it was like you had brought fire to them for the first time. I was like, what? You can do what? You don't have to just do small business loans. So we can influence the regulators to some degree, and that's the scale of that is pretty massive. That's about $150 to $200 billion a year. So it's a lot of money that flows through the banking system that could be better spent and more effectively spent. And then I think the other piece is, and this is something we're experimenting with, we've never done this before, but we're thinking about putting together a prize, like an X Prize type thing, and it's really an upstream social determinants of health X Prize for our region, the 9 western states, and that somebody would come up with a plan in order to sort of say, we're going to improve the social determinants of health in our community, and we'll give them $1 million. I mean, we won't. I mean, Robert Wood Johnson will give them $1 million, but it'll go through us, So those are some things that are in the works.
Earlier in the talk, you mentioned that you don't touch or you don't really work a lot on parks and recreation. And I was wondering, you could have mentioned a quick reason, but I was wondering if you can go into that.
So it's hard. I mean, the things that we work on have to have some kind of an income stream. So whether it's per pupil attendance that you get from the state, or it's rent, that even a small reduced rent that a person can pay for an apartment, or maybe it's some reimbursement from Medicare, Medi-Cal, or Medicaid. If you have an income stream, you can leverage the debt. You could raise money. But Parks and Rec is very hard to figure out where. I mean, you can't charge for people going to the park. We can't get the income stream to work. That's part of it.
So we probably have time for just one more question. I'm sorry, it sounds like there's a class after. So, yeah.
What about crowdsourcing, for instance? You know, when a person or a group of people need to raise money for something and they put out the word, and I think people are more likely to donate if they know that a lot of the money that they give is not taken off for overhead.
Yeah.
So what about that for things like parks that have no return?
Yeah, no, that could really help. And in fact, that not only is that a great platform, and we've done a lot of work around that. In fact, the Jobs Act of 2010 incorporates some research that our colleague Ian Galloway did on peer-to-peer lending that's now changed the SEC rules to make crowdfunding more accessible to more people. So we think there's a democratization of capital with that tool. So we are really excited about that. I think its implications, though, are even greater than just that, because basically there are too many dollars chasing too few investments. And my colleague Robin Hackey says it's like capital's like an airplane, and it's looking for places to land, but there are not enough landing strips. And when a community comes together to build a park, then the real estate values will start to firm up. There's a lot. It becomes more investable in many ways. It sends a signal to the next group, maybe a community foundation, to kind of build on that. And then you can start seeing the way this capital starts getting sequenced, because only in risky places, only grant money goes. That's philanthropic money or government money. But as it gets a little bit more light to a community, you can see things like crowdfunding would be helpful, or some of these other below market rates, socially motivated investors could come in. But if it really starts to take off, then you can bring the banking system in, and then you're off like a rocket. Because the amount of money you can tap, we're talking about $1 trillion, not $1 million, when you can get a place investment ready. And so that's why that move, I think, is really an important precursor for bringing more capital in addition to just being a good thing. That's a great question.
So I know there are probably many people with more ideas. So my final question for you is, how can people follow up who in the room have great ideas about this connection?
So I would love, so one place is this buildhealthyplaces.org, and they're doing a really cool, they're doing blog posts, they're trying to connect people and keep the momentum going. We do the same on our book website here. I'm happy to send you the book is free, and I'm happy to mail one to you. Just go online and you can order that. Those are two ways I can think of right off the top of my head. But I also do a lot of publishing, so I do working papers and articles and other things. So if you have ideas you'd like to write about, I'd be really eager to sort of have that put into you'll get that out to our network of banks and nonprofit banks and foundations and others. So I think that would be a great way to bridge your world to our world.
So I'm sure I'm not the only one who's really excited to hear these bridges beginning to happen. So just please join me in thanking David Erickson.
Thank you very much. Thank you. Appreciate it.